Hello, everybody, and welcome to the Coherent Health Podcast. I'm your host, Christian Navarro-Torres, and with me I have my beloved colleague, Dr. Lacey Venanzi. And today we're going to be talking about sleep apnea as one of the perhaps clearest examples of how a structural problem could become a whole body chronic illness problem, right? If your airway collapses, your oxygen drops, your nervous system wakes you up, your stress chemistry spikes, your sleep architecture fragments, and then we're wondering why, we have fatigue, brain fog, anxiety, blood pressure issues, and all of those things. So this episode is about all of that in the context of sleep apnea, and not just as a sleep disorder, but as a physiological disorder that impacts different things. And thankfully, Lacey knows a whole lot about this. This is something that she works with as part of her routine clinical practice. And today we're going to learn a lot about how she thinks about sleep apnea and how she perhaps goes about treating it or addressing it. Yeah, so I'm really excited for this. Are you also, Lacey?
Oh, so excited. So excited.
Just to put this in context for people to how this problem is in the population at large. In this podcast, we talk a lot about chronic illness, focusing often on things like chronic inflammatory response syndrome or CIRS or biotoxin illness. But this is one of those things that it's not just a problem in those communities, but a general population. So here's a study from a journal called Lancet. Specifically, I think it's Lancet Respiratory Medicine. Lancet is a very prestigious journal. It's a recent study, I think it's from 2020, and they made a global estimate of about 936 million adults between the ages of 30 and 69 are hypothesized or expected to have mild to severe obstructive sleep apnea. And about 425 million may have moderate to severe sleep apnea. And then a more recent study in the US in 2024 put adult sleep apnea prevalence around 32% or about 83 million US citizens. And again, this is in 2024. And, these are estimates, right? It depends. There's going to be factors that will impact these estimates, like diagnostic criteria and assumptions about the population, right? And then at the same time, there's all kinds of links in terms of health outcomes that have been laid out in terms of how sleep apnea is predictive, many different things. And we're going to talk about all of that, and Lacey's going to unpack that. And here's the other part of the nuance here, which is the U.S. Preventive Services Task Force, which is, I believe, a government agency, says that the evidence is still insufficient to recommend universal screening of asymptomatic adults, right? And so there is an acknowledgement that this is common and important, but basically mainstream medicine is still struggling with who to screen, how aggressively to treat it, and how to interpret sleep data in a clinical context. So there's this tension right now with this construct. And it's kind of crazy thinking about how many people suffer from this issue. So those are some basic stats. Maybe we can start, Lacey, by just defining what sleep apnea is, if you have any basic definitions of how you think about that. Yeah.
Yeah, so sleep apnea, there's a couple categories. There's mild, moderate, severe, but the oversimplified explanation is you stop breathing multiple times throughout the hour, and that is called an apneic episode. So an apnea is literally you stop breathing, you hold your breath, or you are basically choking to where you're getting no oxygen into your body. But there are also things called hypopneas, which is a decreased taking in of oxygen. So you decrease the take-in of oxygen by 30 to 50%. And that is really common also in more obstructive sleep apnea, to where you have narrow airways and, it feels like you're breathing through a bar straw. So both will get you the diagnosis. And most people will have a mix of apneic episodes and hypopneas, but both of them are really important to know and to optimize, because it also helps you understand what type of apnea you have and how to treat it efficiently. So I believe that the starting criteria is 10 episodes an hour. And then severe, I had someone that was having an apneic episode every 30 seconds an hour. Are they even sleeping at that point? So yeah, it can literally be up to that point, but that's sort of the start of sleep apnea and how it can escalate. Yeah.
Wow. That's, yeah.
Crazy to think about.
The other thing we were just talking about before starting the podcast was how that estimate of 32% of US Americans might even be an underestimate. And you were
I think it
commenting
is.
on
Yeah,
that.
I think it is.
Which is, I mean, so that estimate puts 1 in 3 Americans are something like that are probably dealing with this problem, but really could even be higher, which could start making us think, oh, is it half of the population that's actually dealing with this? Because, I mean, and you pointed this out to me, right? That I don't have any obvious signs of sleep apnea. And we've talked about how you do have what looks to be an atypical form of sleep apnea. And I mean, I wonder how many people fall in that category where they don't have the classic issues or symptoms and they're still struggling with that. And those people are not going to be easily detected in these epidemiological studies, essentially.
Yeah, I think a lot are. And I think that the bias in providers is, obese males or, males with a
Mhm.
lot of heart disease and metabolic syndrome are who they pinpoint of having sleep apnea. And that's just, yes, for sure. But that's not the only population. Like they say 1 in 4 women and 1 in 3 men. But I mean, I'm 130 pounds, 5'5", and had raging sleep apnea.
Mhm.
And I see it all the time in women, thin women, larger women, people of all shapes and sizes, because it really, yes, if you are carrying more visceral fat in your body, and we've all seen those men that just have like really big, thick necks or that have a lot of
Mhm.
fat around that
Mhm.
area.
Mhm.
And that, in a sense, is going to be constricting their airway, constricting the esophagus. So you really have to think of sleep apnea as a structural situation, at least for obstructive sleep apnea. So, yeah, if you're obese and you have more pressure on your airway, absolutely. But a lot of thin people have underdeveloped jaws and they'll have really narrow jaws and really narrow palates, and their jaw will not develop going forward. And so the airway is compromised that way because
Mhm.
everything is narrowing in that sense. And then the nose, right, narrows from all the upward movement of the palate. So we can get into the nose dynamics a little bit later, but that's why sleep apnea, obesity is just one physical cause, a physical obstructive cause, but there are many obstructive causes. And I would argue that they happen more in thin people. So yeah, I think we have to change that bias a
Well,
lot as practitioners.
tapping into something that I think it's very important that I don't think it gets the attention sometimes that it needs in terms of how to think in terms of constructs. And so the phenotype is what you're talking about, that there is a phenotype or a subgroup that's very representative or very prototypical of sleep apnea, but then there's different phenotypes. And what I'm hearing you saying is that perhaps mainstream medicine is very tuned into one particular phenotype.
Yeah.
And that has all these characteristics of weight, obesity, and then gender asymmetries or prevalences and things of that sort. But not hasn't done necessarily a good job at identifying the other phenotypes. And perhaps this is where functional medicine is a little bit more tuned into looking for other variations of this problem, essentially.
Beyond functional medicine, functional dentistry. I mean, functional dentistry is leading the fight
Mm.
on this. Airway dentistry is leading the fight on this. ENTs that are seeing things a bit more outside of the box, like they are really pioneering this work in this. And then I think, actually, I don't know. If I think about my functional medicine friends, I mean, Dr. Doringer is a huge pioneer in the functional medicine space of this too. This is where I learned a lot of this. And then through my own airway journey, I got deeper into it. But I want to say one more thing about the phenotype in Western medicine, and that is, I think a lot of times the reason why sleep apnea is considered more in males that are obese or males that have metabolic or cardiovascular issues is because this is such a cardiovascular risk, not only from the literal vibration that happens. So when you are obstructed in the back of your throat, this is why you snore a lot, right? But the snoring vibrations that you make literally vibrate really intensely in the back of your jaw and go right down into your carotid artery. So it is a major risk factor for throwing a clot in those arteries. Um, Not only that, so that's the structural component of it, but from a biochemical component of it, When you are chronically depleted of oxygen, you alluded to this in your beautiful intro, but when you have lost your cortisol rhythms as you're sleeping because you're stressed out of your mind because you can't breathe, that majorly shifts coagulation in the body as well. So high risk for coagulation when we don't have that oxygen in our body and when we have the inflammation and the stress hormones from poor oxygenated sleep. So we know that it's a huge risk factor for cardiovascular disease and for cardiovascular episodes. So I do think that because that population is high risk already, and because this is such an influence on those factors, it's considered more. But someone like me, it's, oh, you have sleep apnea. I wonder how that's affecting you. And there's not a huge risk profile for me because I don't have all these cardiovascular issues, right? But the little spinoff to this, though, is with CIRS and the coagulation issues.
The coagulation issues. Yes.
You don't want another tick in that box, right? We don't want any ticks in that box. So this is going to continue to shift towards that, which, is the last thing that we want in that population.
I am so fascinated, but at the same time, also concerning as a patient to think about these things. But for people who are listening in the context of biotoxin illness, because I know a lot of patients actually don't know this. One of the things that can happen in CIRS and biotoxin exposure, once you've chronically activated that innate immune response in a dysregulated way, is that has implications on the cascade of clotting, the sequences of creating clots or clotting properly, right? Or, so coagulation essentially.
Yeah.
And we see with a lot of patients clotting issues. Sometimes it's a little bit of microbleeding or alternations between those two things. And here we have a situation where there's potentially a structural component that's just shifting that response even more, entrenching it into that particular configuration. So once you've turned on CIRS, this can certainly become an amplifier, and it may perhaps even block your ability to recover your immune activity into a more regulated state unless you start dealing with this component.
I would even be stronger in that and say it will block.
It will. Okay.
It 100% is an obstacle to cure.
Yeah.
There is no way a person's body can heal without oxygen, right? You need oxygen, you need light, you need water, you need sugar, you need sodium. Like it's part of the basic elements of what you need to be a functioning human. But oxygen, like this is a silly metaphor and I'm totally taking this from Dr. Dorninger, but you can live, 28 days without water? I think that you can go, that's long as someone went. You can live 4 minutes without oxygen, right? Maybe. I think people have gone longer than that, but I mean, it is so important for the functioning of your body. So if you're, getting 50% of your oxygen needs, which is mild to moderate sleep apnea, 50% of your oxygen needs, there's absolutely no way that you're healing, right?
So, well, I'll save this for this next section because I wanted to follow up on the vibration component because that made me think of something. I'm like, oh, here's an interesting connection, connecting it to the brainstem. And so I want to make that connection in a moment, but let's formally shift into the health outcomes component, which we already started talking about. So, why is this a problem beyond just bad sleep, which is, I think, kind of the surface level assessment from the patient side? Well, it turns out that sleep apnea, again, is predictive of all kinds of different health outcomes negatively. And maybe we can touch on what some of those are. And then I'll bring back this brain piece in there somewhere.
Sure. I would start by saying that everything is going to be influenced by not having good sleep. But from a basic level, recovery, right? So in order for your body to recover, it has to get into deeper levels of sleep, highly oxygenated sleep. So if that's not happening at the cellular level, you're never repairing. And it's also why poor sleep or even shift working, where you're literally not sleeping overnight, is one of the highest risk factors for autoimmunity not healing. So because, again, your immune system needs to heal within the hours of 1 to 4 a.m. So it also gets into more of a circadian rhythm nuance of, it's really best to be in bed 2 hours after the sun sets and to rise with the sun rising. And then in that time, having really efficient, highly oxygenated sleep so that your immune system can recover, your muscle fibers your DNA. It's also where you have a lot of autophagy when you sleep, which is kind of going in and cleaning up cells that aren't working efficiently and getting rid of them. So the entire way that your body recovers, it's also when you're in a fasted state for your gut and for other metabolic processes, and they rely on oxygen rather than glucose or other macronutrients. So it sets the stage for every single process in your body. So when that doesn't happen, infertility, autoimmunity, chronic inflammation, degeneration of the brain, degeneration of tissues, heart disease, stroke, everything, like literally everything goes wrong when you're not doing that. And that's why we see that the sickest people that we have are the ones that are not sleeping, because it's literally that important.
Let's put it this way, in the context of a chronic illness like CIRS, where really repair happens during
Repair, yeah.
sleep. You mentioned this, just like it doesn't matter how much VIP, intestinal peptide sprays you do to try to induce repair in the brain. If you're not sleeping, there's no opportunity for repair, because that's when repair in the body largely takes place. There's all kinds of processes that wake up during sleep, and the brain behaves differently. There's firing activities, there's lymphatic activity, clearance. All
Yeah.
these things start happening during those hours. And the main ingredient there that holds all of that together is oxygen. So if you don't
Yeah.
have oxygen, it's gonna be hard. And it doesn't matter how much you're adding all these treatments that are supposed to be restorative in something like CIRS. But maybe we can talk about, what about something like longevity or mortality?
Yeah, I mean, it's a huge risk factor for that, or it is a really big variable in shortening your lifespan. So the estimates that I've seen are 8 to 10 years off your life for untreated sleep apnea. The risk for heart attack and stroke, I believe it increases your risk of those things by 300%. Your risks of Alzheimer's and dementia, I think, were similar, around 200 to 300%, that it increases that. So yeah, because you're not getting oxygen. So there's a really silly metaphor that, again, I stole from Dr. Doringer, but I tell this to all of my patients because I think it's a really visceral image of what's happening to you, because this is literally what's happening to you. So picture there's a ninja that lives underneath your bed, and you go to sleep, and that ninja creeps out, and he gently puts his hands around your throat, and he strangles you. It's like this slow grip around your neck to where you cannot take a breath in anymore. And you go, trying to get out of it. And then he loosens his grip and he creeps back underneath the bed. And he does that to you 10 to 50 times an hour, right? There's no world in which you would be sleeping well if that were happening to you every night. But that literally is what's happening to you every night. And so when we put this silly ninja image, there's like a sense of threat and there's a sense of fear and there's this like, oh my God, that sounds insane. But that's actually what's happening to you. Your body is thinking, I'm drowning, I'm dying, I'm being strangled. And this is why cortisol spikes, oxygen drops. So when we're detecting sleep apnea in people, the cheap man's way of looking at this, if you have an Apple Watch, or there's like a Whoop watch too, but there's a ring that you can wear. But basically the metrics that you're looking at is you're looking at your pulse rate and you're looking at your oxygen saturation. Because what happens in an apneic episode is your oxygen drops and your pulse rate skyrockets. So depending on if you're an athlete or not, low end of pulse rate would be like 40 to 55. And then, 40 to 70, let's say, would be resting heart rate when you're sleeping. So if you all of a sudden are at 140 in the middle of the night, highly indicative that something very stressful is happening to you, which is an apneic episode usually. And then your oxygen should really be staying 96 to 98%. And that sucker drops to 88% or 85%, right? Huge issue when you're sleeping. So that's the episodes that we're looking out for. But this is why it can cause things like Alzheimer's and dementia and brain degeneration, because you've starved your brain, you've strangled yourself, you've drowned for a minute in your sleep. And now your body has to recoup from that. And now if you're doing this for 10, 20, 30, 40, 50 years of your life, of course these things are going to happen to you. It's super logical that they would.
So I am pulling up here a study, and this is a well-known cohort. I've heard of it. I've never actually read the studies carefully. It's called the Wisconsin Sleep Cohort Study, and it's perhaps one of the largest cohorts looking at sleep apnea and how it predicts all kinds of things, including increased blood pressure, hypertension, stroke, depression, and mortality, which you alluded to at the beginning. Yeah. Then there's other studies kind of replicating these effects. But cardiovascular disease is definitely the bigger category. And then that can be connected to things like Alzheimer's, in addition to other things.
Sure.
And so where does this lack of oxygen or oxygenation rank in terms of the broader categories that predict, high quality life and then mortality and things like that? Grip strength is one that I know we've talked about. Where do you see that ranking?
Oh, top 3 for sure.
Top 3.
Yeah, if not number 1. Yeah. Muscle density and composition, like the amount of muscle that you have in your body, grip strength, sleep apnea, or, proper oxygenation in your body. Yeah, I would say that those are easily top 3 markers of longevity for people.
Mm-hmm. Yeah. And then one of the other things that has been pretty well established in terms of correlation and predictive value of sleep apnea is how it impacts the brain. And so there's studies, actually this Wisconsin sleep cohort found sleep apnea to also be predictive of depression. So mood disorders. And then there's other literature connecting it to attention, working memory, and executive function problems. And then there's the structural part of the brain. And I'm going to bring back this whole thing about the vibration, because I'm like, oh, that's so interesting, because now I'm thinking the vibration, to me, it makes sense that it could impact brainstem activity as a result. The brainstem is a brain structure that's recording its version of sounds around the environment, and it literally stores like a copy of, let's say if you're hearing like a song or something, and it kind of like, you can reconstruct those things by looking at activity in the brainstem, frequency activity. And I'm thinking, man, like that information going into the brainstem constantly has to be problematic. And in fact, I was just looking into this as you were talking about this, that there is in fact a connection that's been established with chronic snoring vibrations in the form of physically damaging upper airway nerves, which in turn can alter brainstem nerve function over time. And now you're dealing with this cascade of autonomic breathing and heart rate issues coming from the brainstem impacted by this component.
And so we didn't touch on this yet, but there is a form of sleep apnea called central sleep apnea, which is an issue in the brainstem, like your autonomic functioning in breathing mechanics. And it's much more rare, but that can happen. I've had one patient in the last 8 years that they ended up having that. And I mean, the reality is that that's what's happening is you have to be on a CPAP for the rest of your life, like no matter what. You're not gonna, widen your jaw out of that. That is something that is happening in the brain that, you can't overcome without having treatment that way. But yeah, I mean, inappropriate aggressive vibration right next to a really delicate sensitive structure is, it's a really dramatic thing that can happen with that. But I wanted to go on a little bit of a tangent on how low oxygen can affect the brain in terms of mood disorders and also in terms of attention deficit disorders. So Australia is the only country where before you are allowed to put a child on a stimulant, you have to have a sleep study that they've passed. And I just think that's so brilliant, but also so smart, because when you are not oxygenated as a child and as an adult, your brain is not going to have proper executive functioning, right? That frontal lobe is going to be like, see you later. So this develops things like ADD, ADHD, mood disorders. So before medicating your child, and I always give this advice to my pediatric families, is this child needs to have a sleep study. This child needs to have an oral examination to see if there's obstruction going on. And not to say that then you can't pair that with medication sometimes, but this child's brain is acting this way because they do not have oxygen right? And it's the same thing. Like if you just think of a night where you've had really terrible sleep and you wake up the next morning and you're grumpy and you don't want anyone to talk to you for a couple hours and you can't find words at your job and just like getting a task done feels absolutely impossible. Imagine how that would feel as a little person, 3 to 5 years old, where that part of your brain isn't even developed yet. That limbic system isn't even an adult yet. So you're already having issues with navigating your emotions. And now you have no oxygen in your body. There's no way, right? And I struggle to give examples like this because they're not always this dramatic. Again, always roll this out in your child if they have behavioral issues before putting them on medications. I think that is just standard of care. But I recently had a patient who was on the spectrum. He's 3 years old and severe sleep apnea. And we knew that he had severe sleep apnea and we were, navigating the options of treating that. And one of the things that you can do is have adenoids and tonsils removed. There's a lot of nuance with whether that's the best thing or not. But in this child situation, his sleep apnea was so intense. Literally, his throat looked like breathing through a straw. He had those removed. A week after this surgery, this child became verbal and literally started reading. He had never been taught how to read. He started learning how to read and spoke. He went from 5 words to 200 words in a week. And it was one of the most
Wow.
dramatic changes I saw. But this cute kid would come in and he would talk like this. He had this froggy voice. I could never hear him. And he was constantly had his nose stuff like this. And it was just this kid is drowning. He's literally drowning all the time. And so it's just, again, I'm so passionate about treating it in kids because their brain can't function without it. And your life will be so much easier getting the resources for these children. But, God bless, we are starting to have many more resources with children with special needs. And we just need to bring this into the equation of all of the things that we're looking at and, interviewing in this child to know what's the best approach for them.
That touches on the other point I wanted to make, which is thinking about how something like sleep apnea can potentially impact brain structure. And certainly brain structure development is implicated here. And I wanted to single out, so there's a whole body of literature connecting sleep apnea with structural abnormalities, both in gray matter and white matter. I think the white matter component is something I was thinking a lot about because when you have poor oxygenation, poor blood flow delivery to the brain, one of the most vulnerable structures to that shift is the white matter tracts. And for people who don't know, the white matter tracts in the brain, think of them as your interstate highways connecting long distance brain regions so that there's very efficient communication. And the way that happens is the white matter tracts are composed of what we call axons, which are like these long distance routes connecting different neurons or cells in the brain. And those axons are coated in what we call myelin. And myelin is like this fat that wraps up the wire. Think of the axon as a wire and it's wrapped up in rubber. In this case, it would be fat, right? And one of the things that has been correlated with sleep apnea is white matter lesions, increased white matter lesions. And usually what that means is there's what's called demyelination, meaning that rubber or fat that's protecting the axon or the wire is breaking apart and exposing the wire. So imagine if you had a live wire that's chipping electricity out because it's exposed. And that's what starts happening when you have demyelination. And one of the stronger connections here has been with white matter lesions, which I think it's interesting. It makes sense because, again, white matter tracts are particularly susceptible to shifts in oxygenation into the brain. And then you will see this often with CIRS patients when you do things like a neuroquant, quantifying brain volume abnormalities, right? And all these different structures, including the white matter. You will not always, but often see patients with white matter atrophy. And then they'll have elevated hypointensities, which could be correlated with white matter lesions. And often those patients tend to have a profile where there's just really bad oxygenation issues or poor blood flow delivery in general. So I wanted to connect that. And then the implications for that in a child who's developing, there's going to be impacts if there is poor oxygenation into the brain during the developmental years, the first 8 to 9 years. It's going to put, depending on where it happens or when, I should say, in that developmental trajectory. So if it's really early on, there could be a lot of implications for the gray matter abnormalities. But for white matters, the white matter tracts particularly are very susceptible because unlike gray matter, where you have the way gray matter develops, it's a U-shaped effect where there's this overgrowth very early on in neurons, and then there's this pruning effect, and that happens very relatively quickly compared to white matter tracts where it's this just linear, gradual, slow increase in development that can go all the way into the 20s. It's a very slow, so there's a lot of vulnerability there if during just not even the first 5, 6, 7 years, so all into your early teens or teens, if there's issues with oxygen delivery, the white matter tracts are particularly very susceptible to problems there. So I thought that was fascinating once I made that connection.
And just to share a personal story of that, MS was thrown a lot, or was that diagnosis was thrown around a lot for me when I was in high school. I don't think that I actually had MS, but I did have white matter tract lesions, but I had raging sleep apnea and celiac disease, which to me are the two most underrated white tract lesion causing diagnoses. And when I treated those, my white matter lesions went away.
That's crazy.
It's something, again, that just needs to be in this diagnostic toolbox for people, of these more outside of the box things to look at when someone comes in with white matter lesions. Because there are a lot of these MS presentations that don't make sense a lot of the times. And people are like, well, I guess we'll just diagnose you with MS because you have enough of the criteria, but you just really don't, it doesn't really seem like it. And I would say in those situations, sleep apnea and celiac disease are really important to work up for them. Yeah.
Yeah. And just to add to your personal anecdote, my neuroquant showed, pretty bad white matter tract atrophy and patterns consistent or correlated with potential white matter lesions. So a lot of issues there. And again, you're someone who's pointed out you look like you have a pretty bad sleep apnea issue. I've also measured my oxygen levels using these devices you put in the finger, and percentages are consistently below what would be considered normal when I'm sleeping. So there's all these things, and I'm, like you said, I'm very thin. I'm not someone that deals with overt weight problems in the form of obesity. I've never have. I don't have any obvious, characteristics in that type of phenotype. Yet here I am, and it seems like it is a very pervasive problem in my situation that may have been all along present since I was developing.
Yeah, well, let's talk about that. Why is this so prevalent, and what are the origins of structural sleep apnea? So it really comes down to jaw development for people. And why is it that now we're seeing, especially in our generation, our children's generation, these statistics continue to climb? And I believe it's because of the jaws that we have these days. So there's a lot of theories as to why that is. Weston A. Price really studied this in terms of indigenous diets and indigenous habits of people, and how they had these really beautiful wide jaws and wide noses. And it was because of the nutritional density that they were getting in their food. But also beyond that, they were exercising their jaws in very different ways. We give kids pouches all the time, which, if you think about that, doing that literally encourages narrowing of the jaw and closing of the airway. But chewing, getting anything was like when you think about a little kid and baby-led weaning and you just give them a carrot instead of a puree, they're exercising their jaw, and it's bringing their jaw forward into development, right? I see. Do you have a comment on this?
Well, I'm just thinking about my upbringing because I just growing up, I was obsessed with baby food. I remember sharing this. It's just funny, but I was obsessed with the banana one. But I just remember I ate that, so I lean onto that as a food source. So lack of training, if you will, very strongly. I'm thinking, I don't think I had a proper exposure to chewing dynamics growing up.
No, and a lot of babies don't. And not to say that there's not a legitimate choking concern, giving babies big things that they can chew and just it's like anything, they're practicing that habit and that skill and not teaching them to prefer easy liquid sources of nutrients. We want babies to work for their food. In the same way, even before this, breastfed babies or non-breastfed babies is where this starts as well, because the way that babies latch and the way that suction works on their mouth, it literally is this force that pops their jaw out to expand, right? And there's a very specific tongue placement, and their lips need to be curled like up and down like that around the nipple, right? So if your baby has this like little sucking type thing, that is going to be prone to a narrow development of the jaw rather than this really open, pressurized feeling in their mouth. So getting lactation consultants, having your baby develop a beautiful, large latch is the origins of this, right? Even before that, what you're eating in pregnancy, what your mom was eating in pregnancy is going to have these stamps moving forward of then what your baby has to draw from as they develop. So a lot of our babies, especially babies that are third, fourth, fifth born from a mother, are going to be very depleted in minerals because mom is very depleted in minerals, especially if you've had your babies really close together. So we all know this as moms when you're pregnant, your teeth go to hell in a handbasket. And it's because baby is taking all of your calcium and magnesium and phosphorus and all of your minerals, right? And so if you don't come into that pregnancy really high in all of those things, it's going to come to baby first and then it gets taken from your tissues. So you end up getting really depleted. So you can imagine if this is your fourth or fifth kiddo, you don't have anything else to give to your baby. So then the building blocks that they need to develop their jaws and develop their bones, they're going to be really lacking in that. So, and you can see this in third world children that are severely malnourished and they get that really gaunt skeletal look, and it's because they just don't have the nutrition to develop those bones. But so there's many factors here, right? It's the health of the mother in conception and during pregnancy. It's the ability to breastfeed and how great that latch is for the baby. It's what kind of food you give your babies. I mean, I'm really against pouches, really against them. It's not good for jaw development for babies. I'm not against purees, but give it to them in a spoon, right? Rather than a right feeling of that. The
Yeah.
sucking should really
Yeah.
be reserved for your nipple
Yeah.
and nothing else. And then as baby develops and starts to get older, how is their jaw developing? Do they have lip ties? Do they have tongue ties to where they can't latch and then they can't expand? So if you have something up here tying your jaw to that tissue, your jaw cannot move forward. It's literally being pulled back this way all the time from these frenulums that you have in your mouth. So that's really important to, I still need to get my tongue tie released in the bottom of my tongue. That's the last step in my journey. But you can screen for this in kiddos. The younger they are, it's pretty much pain-free. It's a little laser that just goes and zaps through that tissue. And then their latch is beautiful. And now you're not holding back their jaw from developing.
Wow.
But let's say you do, this is where I'm at, right? I have a narrow jaw. My son, unfortunately, has a narrow jaw. His dad has a narrow jaw. He's going to have to do some expansion. So expansion really isn't indicated till about 3 years old, but there are devices that you can get screened for from airway dentists primarily that can gradually encourage the jaw of pediatrics to expand as they grow. There's many different types that people can do. Some are less invasive, some are more invasive, but like this is absolutely something that I'm going to be doing with my son, right? Is he will get that installed so that as he grows, his jaw doesn't have a choice but to expand so that he doesn't end up with sleep apnea like me in his 20s.
I see. There's one thing I want you to talk about, which is I was fascinated by when you made this point of how structural issues in the jaw could connect to spinal alignment issues. Because
Yeah.
I've never thought about that connection very intentionally. You know, when
Yeah.
people complain about the shape and then they're very, what's the word here? they're very tense and they're trying to do workouts, and like their thighs and the muscles in their thighs are very tense, and then the hips are really, really
Mhm.
tense. They think of that part of the body, all of that network, but I don't know if I've heard people talk very intentionally about what's going on upstream in the mouth.
Yeah, gosh, I wish I could pull up a picture right now of
Oh
it
yeah, that
illustrating
maybe
it.
yeah.
Maybe we can tag one, but it's to me, it's really obvious once you look at a skeleton and when you look at the nervous system, right? So they have those really cool images where it's just the skeleton on top of the spine and you can see the interconnectedness from just even bones, right? So we'll talk about bones and then we can talk about nerves and then we can talk about fascia and how they're all interconnected. But yeah, your spine and your skull are connected to each other. Your skull sits on top of your spinal column and the dynamics of your head is bobbling on the top of your spine, but any dynamics that push down on your head or tilt your head or rotate your head are going to have a direct impact on the top of your spine where that sits. So if you're doing anything that's going to compress your skull, it's going to have a downward force on your spine. And a lot of times you'll feel that force really dramatically on the very top of your spine.
Mm-hmm.
It's got C1, which is the top of that column. And then the occiput is really your skull and where that sits on your spine. But yeah, if we're talking about your jaw and you think about your jaw as a drawer, it can pull out and it can pull back. And it's this swinging joint that you have right here. But as that pulls back, and you can feel it, like if you were to literally push your jaw back,
Yeah.
where do you feel it? You feel it right at the top of your spine, right? It's
Mm-hmm.
called your
Mm-hmm.
CT junction. So you push that back and you immediately feel that pressure there. And that's where most people are living. Most people are living with their jaw completely pulled back that way and underdeveloped. And you can see it in people's profile where their jaw, so your jaw and your upper lip should be in line with your forehead. So if you look at someone's profile, all of those things should be in line. But for a lot of people, this ends up being tilted backwards.
Mm.
And so that is going to put that pressure on your spine. And as that goes down your spine, you can get scoliotic curves. It can land even further down in your pelvis, and you can get tightness in the sacrum or the hip sockets. It's like there's so many versions of how this can play out in people's bodies. And it's a really interesting deep dive when you look at this concept of malocclusion or teeth being pulled in someone's jaw and then how that has these ripple effects to the dynamics of their skeletal structure lower down. And this has been studied and taught in osteopathy for a very long time, that if the hips have an issue, look at the jaw.
Mm-hmm.
So especially the back molars. So there's a lot of this interplay happening. And again, I am an N of one, but I had very late stage onset of scoliosis as a 17-year-old, where I went from no curvature to my spine to 56 degrees in 3 months. And the only factor in that time that changed in my health is I got my wisdom teeth and my next set of molars pulled. So I had 8 teeth pulled within a 2-week time frame.
Wow.
And 3 months after that, my spine went to the side. So what was happening is my teeth were pulled out, and the explanation, this happened a lot in dentistry in the 90s where your mouth was too small and your teeth were too big. So instead of expanding your jaw, let's just pull teeth and then we'll pull your jaw back, or we'll pull your teeth back to make that perfect smile. But you've literally just given me sleep apnea, right? You literally pulled my jaw back into my throat to get a perfect smile. And now that pressure that went back just reverberated down through my spine and whoop, went off to the side.
Wow.
So it really needs to be looked at, especially at late stage scoliosis with people. But yeah, there's massive effects that can happen, even from a structural standpoint. If we're talking more about muscles and fascia, when you pull your chin back like that, you can feel the entire posterior chain of your body go, huh.
Mm. Mm-hmm.
And that feeling is a sympathetic nervous system state,
Mm-hmm.
right? Your body, and it's kind of brilliant when you think of why your body does that. In order to run away from a lion, you need to have stiffness and strength in your back so that your quads can run like hell, right? So it's a great mechanism in that way, but then you get overdeveloped quads and tight, weak, underdeveloped hamstrings. And this is me in the gym all the time. I'm not like a crazy
Well,
weightlifter,
with
but
the squatting, how you're targeting those muscles or not
totally. But even if I break it down into training those individual muscles, like what I can do with knee extensions,
knee
what I
extensions.
can do in knee extensions is dramatically more than what I can do with curls, which is quads versus hamstrings. There's a huge discrepancy that happens there. And you'll see this especially in ADHD boys where they can't touch their toes. Their hamstrings are so tight, they can barely even touch their knees. And it's not because their hamstrings are actually physically shortened. It's because they are living in a sympathetic state from a lack of oxygen. And so their body just keeps them like a slingshot ready to go at any moment's notice. And it's also why they're great sprinters. They can run forever. They're really great cardiovascular athletes. And it's because their body is primed to sprint all the time. But they would be terrible at karate or jujitsu or gymnastics or anything that would require a lot of flexibility and dynamics because of their brain chemistry. So it's because of a lack of oxygen.
Man, I wish I had this thinking before I got sick with CIRS and was doing a lot of physical activity, strength training, and functional exercises, thinking about, informing how to like engage muscles better, thinking about,
Yeah.
all these upstream components that I think is fascinating. This is a little section for those of you who are thinking more about exercise and gym and it's a fascinating connection. I think maybe we should shift gears a little bit. I do want to make sure we have time to pick your brains, Lacey, on how you go about assessing sleep apnea as part of your practice. What are the clues you're looking for? Are you following a kind of a standardized assessment or diagnostic procedure? Are there things that you will look into that are outside of that? And then how do you think about potential root causes connected to that? If there's anything driving or contributing to that. Obviously, we talked about the structural stuff, the developmental stuff, but if there's anything else that you factor in, and then how you go about treating it.
It's not hard to test for, right? It's also something that if you were to go to your primary and say, I never get restorative sleep, my boyfriend says I snore at night, I wake up tired every morning, it's a no-brainer to run a sleep study. And like many conventional doctors will do that for you, no questions asked. So advocate for yourself. It's honestly just, I think, a really good thing to check off your list, especially if you're someone that struggles with chronic illness or chronic fatigue or neuropsychiatric disorders or ADHD type symptoms. No brainer to get that worked up. But if you want to do it in the poor man's way, it's like I described of having some of these watches, or there is a device called a looky ring, Lookee. And the device was actually used to, once you get a CPAP, to make sure that it works. So it's a wonderful device, but you can also get it to start to develop some preliminary data of, man, is this actually an issue with me? It's not actually a sleep study device. So I want to make sure I say that. But these are against the poor man's way of starting to collect some data around your situation. But then also you have to think of symptoms, right? So sweating a lot when you sleep. So there is the female menopausal type situation where you have a loss of estrogen. And so you lose your thermostat and you'll get hot flashes throughout the night. This is like you run hot, you wake up sweaty in the morning and like clammy in a certain way because again, you're running sprints throughout the night. So you are going to be in a sympathetic state as you sleep. So waking up sweaty is a big thing. Nightmares, night terrors, and sleep talking or sleepwalking are all highly indicative of having sleep apnea, of which I have hilarious stories of how I did this as a child. But your brain is never getting into restorative sleep. So you stay in this in between sleep that is ripe for nightmares and night terrors and sleep talking and sleepwalking. So, highly indicative of that. Waking up fatigued, feeling like no matter how much sleep you get, it's never enough. Having to take naps in the middle of the day. In children, dark circles around their eyes is hugely indicative of this. structure of your face, if you have a narrow jaw, if you have a bump on your nose, if you have your jaw that is behind the line of your lip and your forehead, you have a recessed jaw, highly indicative of obstructive sleep apnea. If you have these comorbidities of high cholesterol, different heart markers and cardiovascular markers, in CIRS, very elevated TGF beta 1, like above 15,000. The other DDX for high TGF beta 1 is sleep apnea and traumatic brain injury. So you have to work that up. There's a lot of my patients where we didn't treat sleep apnea for some reason, and their TGF beta 1 went down with CIRS treatment, but not compared to when we actually started treating their sleep apnea. So it should be treated at the same time. So symptoms. Symptoms, obviously, snoring. What's interesting is I didn't snore when I would sleep, but I would hold my breath. And I would do this even when I would watch movies. And I remember my husband being like, "Are you alive right now? You haven't breathed in like a minute." And it was just like, "Really? That's weird." And I would just go, "Hup," and I
Ooh.
would just hold my breath. I had gotten into this pattern. So this is the other thing to pay attention to during your wakeful hours. If you always have your mouth open, if you cannot keep your mouth closed when you're just thinking. So watch yourself when you're just working at your computer, and you can take, oh my gosh, you could do this with like Tic Tac, you could do this with those orthodontic rubber bands, like any small piece of something, and you put it on the tip of your tongue, and you want the tip of your tongue to press onto the roof of your mouth. It's like a holding place, and you keep your mouth closed and you hold that. You should be able to do that for hours without it being fatiguing. That's the natural place of where your tongue is supposed to sit. So try doing that. If you cannot do that to save your life, you are a mouth breather during the day. And you have trained yourself to be a mouth breather because of how you sleep overnight. So the sleep posture of people that are like that when they sleep, that's obstructive sleep apnea. Your mouth should be closed. You should be very quiet when you sleep. You should be breathing through your nose. So having someone observe you, comment on that, think about how you talk during the day, how you orient your mouth during the day. Do you yawn a lot? Yawning is a huge sign of lack of oxygenation in the brain. So if you're a chronic yawner, it's actually one of my silly CIRS symptoms when I'm in exposure is I start yawning like crazy, like literally like every 30 seconds. I
Same here.
yawn.
Same here.
Yeah. And so that's a sign that you are in a low oxygenated state. So, yeah, these are all ways that you can start being curious about yourself. But then to actually have formalized data, you need to get a sleep study done. You can do that through your primary. You can also do that at cash rates. It's not very expensive, it's $200, and it can be an at home sleep study. You will get more data at a sleep center, but I would say the advantage of that is they can hook you up to more things to see if you're having more central sleep apnea. So it's not necessary, but that would be the highest level of data. You can totally diagnose yourself with sleep apnea with an at-home sleep study. And we can put in the show notes the brand that I typically use. I'm blanking on the name of it right now, but they're lovely because you can get a CPAP through them as well. So yeah, that's how you diagnose it. Treatment is a CPAP. This is what's hard for a lot of people is the amount of times I've heard, especially men, be like, "I don't care because I'm never going to wear CPAP at night." And then I give them the statistics of what will happen to them if they don't do it. And inevitably they come around to it. But a CPAP is how you treat this. Now, outside of the box ways of treating this are there's an instrument called the didgeridoo where you can learn to play the didgeridoo. And the reason why the didgeridoo can heal or fix sleep apnea is it teaches you how to do circular breathing, which is a very difficult technique in wind instrument playing. The didgeridoo is not particularly hard to play, but the studies showed that the second you stopped playing the didgeridoo, your sleep apnea came back. So you needed consistent work with that. I've never had a patient like fully see that through, but that is a novel, interesting thing to do. In that same vein, there's very specific sleep training, breathing exercises that I would just encourage all people to do no matter what, because it gets you into a hyper oxygenated state during the day when you're in a deficit at night. I can link those as well. There's a guy named Dylan Petkus that has an amazing, very affordable, it's like $20 a month program where he teaches you all these things that you can do. So that's an absolute no-brainer to start doing that while you're working this up. I even just have my CIRS patients do this because we're so low oxygenated anyways. There is specific forms of cardiovascular training that can also help people with obstructive sleep apnea. Again, more in the realm of hyperoxygenating yourself during the day, knowing that you're going to have a deficit at night. Um, oh my gosh, why am I blanking? Yeah, so then there's more invasive strategies. So if you are a patient that has a narrow jaw and therefore an obstructive airway, you can physically re-expand your jaw. So I'll use my example or my case as an example. So I had wisdom teeth and molars pulled, jaw pulled back. So I had a incredibly narrow palate. Like the millimeter width of my palate was that of like a pediatric palate, basically. And I had lost about 60% of the space in my esophagus because of how pulled back my jaw had become. So I had gone to an incredible airway dentist named Brian Huckle. He's up in Walnut Creek in Northern California. He is one of the leading experts in this field. I highly recommend getting a consultation with him. But he really walked me through this process, which was a 2.5 year process, right? So initially, you do expansion, moving your teeth forward. And I needed to open up the space where my molar should have been. So I had a very specific, almost, what's the right word? Retainer. Like at this point, nothing had been drilled into my face. It was just a retainer that was moving my teeth and separating that space, opening that again. So the first 6 months were that. Now, once that tooth space was open, we were going to focus on widening me this way. And I had installed something called a MARPI. So the MARPI gets drilled into your palate, and you have a suture down the middle of your palate that the goal is to pop that open and expand that.
Sounds
So
so
you get
intense.
it's so medieval. So you get these 4 screws drilled into your palate, and then you're twisting that every night until you literally pop open your palate and that suture. And you keep going and you keep going and you keep going until you have the expansion that you want. Now, you also typically have an expander put in on your lower jaw under your tongue as well. And both of these are permanent, and you're expanding both of them at the same time. So it's intense, man. It's not for the faint of heart. It's really intense and it's really hard to talk. And when you're a practitioner and talking every day, I'd always be like, guys, I'm going to sound like a 4th grader here for a while.
Yeah.
Um, but did that. I think I ended up getting like 15 millimeters of space in my upper jaw, which is wild. I think I have now 90% of like functioning esophagus space in my throat. So I've cured myself of sleep apnea. I don't have obstructive sleep apnea anymore. And then the final stages of that is you don't turn anymore. You just leave the devices, and then that bone fills in your palate. And then you have those suckers removed, and then you do kind of a version of Invisalign to realign your teeth. I have a little bit of a gap in my front teeth now, but I had a really big gap at one point. And then that
Interesting.
Invisalign can kind of bring that back
Yeah.
together. But that gap is from my suture popping open. So
Interesting.
the reason why this is really important also to begin being able to nasal breathe more efficiently is your palate is the floor of your nose. So if my palate was super, super arched like this, the floor of my nose, right, is going to be up in a point. And so instead of that being flat and having like these beautiful triangle open spaces on either side, right, I have these little slivers that I'm breathing through. So really, really high risk of infection in the sinuses, low oxygenation that leads to low nitric oxide in the body. So if you're not breathing through your nose, you're not producing nitric oxide in your body. You cannot do that through mouth breathing. So there's so many crazy downstream effects. Also, there's barriers in your nose that block pathogens from coming into your body. So many gut issues can just come from the fact that you're mouth
Well, and
breathing.
we know it serves right that sinus is a very problematic
Very
part of the
problematic.
body, and you wonder how much structural issues and
Contribute to that.
contribute to that. Yeah.
Yeah, my patients that have either like a deviated septum or, have high arch palates have a much harder time overcoming Marcons, nasal-lactinos, MRSA, whatever the flavor of the day is in their sinuses. It's a major issue because you can't even get those medications up there, right? Because there's so much obstruction going on.
Yeah.
So that's why I opted for the medieval jaw expansion. And then oftentimes the last stage of this is jaw surgery, where they literally then break your jaw and move your jaw forward, which my sleep apnea, I had checked in at the end of my expansion journey and it was 90% solved. So I was like, I'm not going to break my jaw and go through all that. When I feel like I'm pretty much fixed at this point, but that
Yeah.
typically is the last part of that. And there's pros and cons, but it was totally worth it. It was a massive, massive shift in my health when I went through
Wow.
all this. Yeah.
Wow. What about, we've talked about wisdom teeth removal, root canals, and if when patients have root canals and they end up removing them because it's contributing to their chronic illness burden, is there things that I should be thinking about from this perspective of how that could set the stage for, yeah.
Oh, yeah. That gets a little bit more into the biome of your mouth and the
Mm,
infections that can happen in your mouth. And the problem with root canals and crowns and different things like that is you have so much bacteria in your
right.
mouth and you are creating these little pockets to where things can then go into and cause infection. And mind you, it does take a long time for that to grow into an infection. But the concern with wisdom teeth, the concern with root canals is that something is left behind in that. And then that grows, and now you've just infected that bone, right? So now you've gone into infection in that. And then that can have really dramatic downstream effects of inflammation and disease and infection in the rest of the body.
I would
So
imagine it could impact or influence the jaw's ability if you're trying to fix it. Right.
absolutely. Yeah. You can come in contact with a lot of those things as you're trying to expand that. So it really requires good dentistry. So whether that's biological dentistry, which is a name for functional dentistry, they just say biological dentistry. There's airway dentistry. There's even ENTs though that do this. There's a guy out of LA, Dr. Zaghi, that is really pioneering this as well. That's doing a lot of research in this space. That's Western medicine focused and is doing some really fascinating stuff with this. But that's the team that you would want to take a look at. So again, I think anyone and everyone should be getting an assessment of this, especially with the statistics that we started with.
Yeah.
1 in 3 minimum is the estimate. I would argue 50%, right? And that's, I would say, actually, of my patient population, which is generally sick people, 70% of them have sleep
Mhm,
apnea.
mm.
So if you're a CIRS patient and you haven't worked this up, you need to work this up. This is really, really important in your ability to heal from this. So, yeah.
Do you usually start working on this from the get-go if someone is dealing with CIRS treatment? Or are there things that you wait until, let's make sure you're in a later stage of healing and your body, yeah.
I really push for this early on. There's nothing contraindicated in starting to treat this alongside the Shoemaker protocol. This is foundational work that you have to do in order to heal. So, yeah, I have no issue with that, especially if those symptoms that I discussed, if those are really apparent in the person that I'm working
Yeah.
with, then I'm really going to push for it. I think what's difficult sometimes is some people don't have the finances to go to these dentists because they're expensive. Although I will say, if you do have insurance, a lot of these methods, like my expansion, completely covered under insurance because the diagnosis was sleep apnea. It wasn't a dental diagnosis
Mhm,
that they're like,
mhm,
oh, you need dental insurance. So this is a metabolic issue that is treated via dentistry. So mine was completely covered.
mhm.
So there's a lot of coverage that you can get for things like this through normal insurance because sleep apnea is so prevalent.
And in terms of, in the meantime, there's all kinds of things you can do to promote oxygenation. But a little quick hack that you were the one who introduced me, nasal strips, what role can they
Yeah.
play and how can they help?
Yeah, so there's these breathe right strips. There's a lot of different ones on the market,
Yeah.
honestly, and some of them are annoying because they're very sticky and very abrasive. But Breathe Right is great. It's more of a plastic structural one that I think is really lovely. And then there's a brand called Respire that
Inspired.
they don't use a lot of the glues that are toxic. So it's really effective. And then mouth taping also. So the only thing that can be tricky with mouth taping is that if you're not having the sinus expansion at the same time and then you're closing your mouth, you are actually making worse sleep apnea because the mechanism of opening your mouth to breathe is because you can't get oxygen into your body.
Yeah.
So sometimes that can be challenging for people, but it's worth a shot. And then the other thing that's just super simple is building up a pillow sort of barricade so that you can't sleep on your back. So sleeping on your back is the most disadvantageous way or position to sleep because your jaw inherently is falling back. So being able to sleep on your side, that alone can not fix, but ameliorate a sleep apnea because your jaw's not falling back. So again, simple ways, breathing exercises throughout the day, sleeping on your side, nose tape, mouth tape, getting a sleep study assessment, and then get on a CPAP. CPAPs are life-changing for so many people. The amount of times I've heard people say, "Oh my gosh, I wish I would have done this sooner." You have more energy, your risk of disease and poor longevity goes down, you heal from chronic illnesses and infections in your body, you could work out better. You have better stamina, both physically and sexually, because you have blood flow in your body. I mean, the list goes on and on of what this will improve in your
But
life.
that's a good argument for the males that are like, I don't want to do the CPAP. If you have libido problems, here's
Erectile dysfunction, there are many reasons for it. Blood flow is a huge part of that. And you will have terrible blood flow if you have poor oxygenation. So it has to be on there as a question for people if that's something that's going on. It can be hugely impactful for people.
Wow. Yeah.
The only thing from the pediatric side of it is a sleep study is totally warranted for pediatrics. It's not super hard for them to wear it, but again, they have to be a little bit older because they definitely need to be sleeping through the night and have it monitored that way. But you can talk to your pediatrician about that. Usually, pediatric airway dentists will do a free assessment of your child. And this is where they're measuring the width of their palate and they're looking at how close together are their baby teeth. Or if you're one of those cute kiddos that has a perfect smile that looks like they've had braces,
Yeah.
problematic. They should have 2 to 3 millimeters between each tooth, right? So they should have those like really cute spaced out teeth. My son is one of those that has like perfectly together teeth and they will start to tilt inwards. You'll see kiddos where they're starting to tilt inwards. And again, that's that narrow palate developing. So we want a big, wide arch, teeth straight up and down. We also want them to go back this way rather than, so you can see in my smile now, my smile goes back
Yeah.
instead of straight. We don't want a sharp cul-de-sac. We
Yes.
want a wide rainbow arch
Yes.
going back. So anyways, in kiddos, these are some things to point out, the dark circles. So you can get these assessments. You can also get their lip and tongue tied assessed. Usually it's best to do this with a lactation consultant or an airway dentist, right? Pediatricians do not train a lot in being able to detect this. So my son had a raging tongue and lip tie. And his pediatrician told me many times, "Oh, no, it's totally fine." And it was like, he can't curl his lip up to nurse because it's tethered by tissue, right? So, and you'll see that if you see tissue coming down into the teeth, like literally at the top of the teeth, that is an upper lip frenulum tie. So that you should have where you can just fully pull up your lip and have no tension in doing that.
That's
So
fascinating. I think for me, talking to you about all of this sleep apnea and everything that's connected to it structurally, anatomically, and then has been very eye opening just from the perspective of how do I think about recovering my health in the context of CIRS, not just something connected to environmental exposure, obviously a foundational core component of the illness, but then it gets intermingled with all these layers. And this is, I mean, with CIRS, I think that the big theme here is just how pervasive, how important foundational oxygenation is to the body. And then CIRS happens to be an illustration of systemic poor oxygen delivery. And then adding this into the equation certainly complicates things and how important it is to really make sure we're addressing everything that we need to in the context of having good oxygenation in the body naturally. So
This is a really oversimplification, but I tell a lot of practitioners this when you're working up your patients. You have to chase the oxygen, you have to chase the inflammation, and you have to chase the glucose. And all things related to those networks are what keep a person healthy. The other category that's a little bit more outside the box is you have to chase the light in a person's body. And that sounds really poetic. And it is, for sure. It is. I more mean it on a circadian rhythm basis. And can that person tan? Can they absorb light? Do they have proper circadian rhythms? Do their pupils dilate the way that they're supposed to? These are foundational, should be in your initial assessment. Can my patient achieve these things well? And if they can, they're healthy, right?
Mm-hmm.
If they cannot, you have to chase the causes of those. And for oxygen, the number one cause of low oxygen is sleep apnea in a person's body. The second would be concussion and traumatic brain injury. But you have to chase those things down or you're doing your patient a disservice for sure.
Wow.
Yeah.
This is it's going to sound cliche, but this is very much in the spirit of holistic medicine. I like to think of it as systems level integration, and I love it. And well, with that, I would just say thank you, Lacey, for sharing all of that wisdom. I think this is fascinating and important for patients to really develop healthy awareness around these things, because I think we tend to easily get entrenched into narrowing things down to certain things which are important, but really you at some point have to really start. I like how you introduce those 4 layers, right? And then patients can themselves think about, am I hitting all the check boxes in each of these domains as a patient, for just self-awareness around your own health as a patient as well.
Yeah.
Maybe with that, we can wrap up. Thank you, everybody, for listening. Thank you, Lacey, again, for this amazing information that you've been sharing.
As always, this is not medical advice. So if these topics intrigued you and you want some more information around this, talk about this with your provider. And also, if you want to keep following us and get more information on what we are doing, you can find us at coherencedx.com. You can also submit questions at that website if you want us to discuss certain topics, or if you have questions about the topics that we've already discussed. So thank you for joining us today and talking about this fascinating topic of sleep apnea and oxygen in the body. And we hope you join us next time for our next conversation.
Yes. Until then.